Welcome to Understanding Your Hospices PEPPER webinar presented by the Visiting Nurse Associations of America. Our guest presenter today, Kimberly Hrehor, is a director with TMF Health Quality Institute. She manages a contract with CMS to develop, produce, and distribute the Program for Evaluating Payment Patterns Electronic Report, PEPPER, for hospitals and other healthcare providers. She develops training and reference materials to help providers understand and use PEPPER. Kim's work experience includes health information management, compliance, and performance improvement. I'd now like to turn the presentation over to Kim. Kim?
Thank you so much, Heather, and it's an honor to be able to address the VNAA and talk a little bit about the Hospice PEPPER. Again, my name is Kim Hrehor. I work for TMF Health Quality Institute, which is based in Austin, Texas. And TMF is contracted with the Centers for Medicare and Medicaid Services, or CMS, to develop and produce and disseminate these reports that we call PEPPER. So today I'm going to be discussing the newest release of the PEPPER for hospices and why you might be interested in obtaining and reviewing your report. So during today's session, I plan to talk just a little bit about what is the PEPPER. We are going to review a sample PEPPER so that you can understand what's in your PEPPER when you receive it and what can those statistics mean to you. I'm also going to talk a little bit about how you can get your PEPPER, go through that process. At this point in time, about 56% of the hospices across the nation have obtained their PEPPER. But if you're not one of those, then we'll review how you can access your PEPPER. And then lastly, I do want to talk about how you can get assistance with PEPPER in the case that you have questions or if you're having trouble accessing your report. So what is the PEPPER? PEPPER is an acronym, as many things are that are associated with the federal government. PEPPER stands for Program for Evaluating Payment Patterns Electronic Report. And essentially, the PEPPER is a comparative data report that summarizes one hospice's Medicare claims data statistics for areas that have been identified as at risk or prone to improper Medicare payment. And we refer to those risk areas as target areas in the PEPPER. In the PEPPER, you'll see your provider's Medicare claims data statistics summarized for those target areas and compared with aggregate Medicare data of other hospices in 3 comparison groups: in the nation, in your Medicare Administrative Contractor jurisdiction, and then in the state. And we use those comparisons as the first step to identify where your hospice might be at a higher risk for improper Medicare payments, which simply means that your billing statistics look different from most of the other hospices in the comparison group. So one of the questions on your mind might be, why should I be interested in my PEPPER? The federal government is concerned, growingly concerned, I believe, with the amount of dollars that are lost every year in the healthcare arena to fraud, waste, and abuse. And so, of course, they're invested in decreasing that amount of dollars that really need to be put into and stay in the Medicare Trust Fund for the betterment of the providers and the beneficiaries. So there are a lot of, the providers are, quite frankly, under a lot of focus at this time, and this includes hospices. Traditionally, hospices haven't been such a focus of federal agencies, probably because the sensitivity of the care that they provide, the fact that it's an end-of-life care, and so there hasn't been a lot of focus on hospices traditionally. However, over the past few years, we have seen that change, and there have been a number of findings of hospices that have had concerns with fraud, waste, and abuse. So the providers are under focus. If you just take a look at the most recent Office of Inspector General work plan, we know that there are a lot of different types of providers that have concerns with improper payment. The recovery auditors, the Medicare Administrative Contractors, the Supplemental Medical Review Contractors, and other organizations all have activities that are focused on, again, protecting the integrity of the Medicare Trust Fund. If you look at the CERT report, which is available on the CMS website, the hospice error rate increased from 4.3% in 2014 to 11.4% in 2015, with a projected $1.68 billion in error. Now we know that a lot of these contractors, these organizations, these law enforcement agencies are looking through Medicare claims data on a regular basis in an effort to identify providers that perhaps might be engaging in activities that lead to fraud, waste, and abuse. Their focus is probably more on the fraud side. And so, as a matter of fact, in April I attended a conference where there was a speaker from the Department of Justice who mentioned that they are receiving on a monthly basis a file of claims data from CMS that they use to mine the data and identify providers that they might want to take a closer look at from the federal law enforcement level. I say this because a lot of the statistics in the PEPPER can help identify when a provider's statistics look different from the majority of the other providers in the nation. And so wouldn't you like to know if some of these other organizations are looking through the claims data and if perhaps your hospice sticks out at the top? Would you like to know if your statistics might be a red flag to the auditors or these organizations? And really, that's where the PEPPER comes in handy. It can help you identify when you might be, when your statistics look different, and you might be on the radar for one of these other organizations. Now, within the PEPPER, we identify what we call outliers using percentiles. And as we move more into the demonstration of the PEPPER, you'll see that most likely you can calculate the statistics for a lot of these issues using your own claims data. And so you could probably calculate your target area percent for these target areas. The problem is that when you're just looking at your statistics alone, you have really no way of knowing how do my statistics look as compared to the bigger picture. And so that's why we calculate the percentiles that allow us to sort of identify where we are in the big picture and gives us some context so that we can think about whether our statistics look as we might expect them to, or if there's something that we should be concerned with. And I'm going to talk a little bit more about percentiles as we move through the program today. Now, I've included this slide in here to give you really a visual to help you understand the comparison groups as we refer to them in the PEPPER. So we do have the 3 comparison groups, and so when we're comparing you to all of the hospices in the nation, that is the national comparison group, which of course includes all of the providers. Then the second largest comparison group is the MAC jurisdiction, the Medicare Administrative Contractor jurisdiction. And on the slide here, you can see that there are the 4 home health hospice MACs geographically identified there. We've got National Government Services has 2 jurisdictions. We have CGS and then Palmetto. And when we're talking about this jurisdiction comparison group, that is comprised of all of the hospices that submit their Medicare claims to that individual MAC for reimbursement. So when we're, if you're being referred to or compared to your MAC jurisdiction, it's all of those hospices that submit their claims to that particular MAC. And then, of course, the state comparison group, which is the smallest, is all hospices in a state, regardless of which MAC they submit their claims to. Now, this is one of my favorite slides in the PEPPER, and I hope that you take a look at it. And I'm going to refer back to it later in the presentation. Back to the percentiles and how we calculate percentiles. So when we're talking about the calculating the percentiles, what we do is for all of the providers in a comparison group for a given target area, let's just say this is for live discharges. We'll take those target area percents for all of the individual hospices and we sort them from highest to lowest. So you can see on this slide here that the highest target area percent is 93%, that's at the very top, all the way down to the lowest target area percent at the bottom, which is 2%. So we can see now that how the different target area percents are rated from highest to lowest. And we identify, when we're talking about the outliers, we identify the point below which 80% of the hospice's target area percent fall. And that, in this example, is 85%. So what that tells us is that the top 2 providers in this comparison group, which is a very small, there are only 10 providers, but those top 2 providers are at or above the 80th percentile. And so in the PEPPER, they would be identified as an outlier. So you can see that if there are, say, 1,000 providers that are being compared, sorted highest to lowest, when you are able to calculate the percentile, it gives you the context so you understand where within this distribution do you fall. And with that, I am going to switch screens now and go into a demonstration PEPPER so that we can talk more about these concepts. So when you receive your PEPPER, and you will receive it electronically, it is a Microsoft Excel workbook. And when you're navigating within the PEPPER, you would click on the worksheet tabs that you see along the bottom of the screen. When you open your PEPPER, it's going to open up to this first page that we call the purpose. It's going to identify for you the most recent period or quarter of data statistics that are summarized within the report. And for the most recent PEPPER that was just released in April, that is through the 4th quarter of fiscal year 2015. And the Hospice PEPPER summarizes statistics based on the federal fiscal year. So this PEPPER will contain or summarize statistics for 3 fiscal years 2013, 2014, and 2015. Here on this row, you will see your provider name and number, a little bit of information about where you can find the PEPPER User's Guide. We actually have a link to our website here, as well as a link to the Training and Resources page, which is where additional training resources are available. On this row, we show you the version of the PEPPER. This is version Q4 FY15. And then here you would see your MAC jurisdiction comparison group identified. So it would be the MAC that you submit your claims to for Medicare reimbursement. The second worksheet in the PEPPER is called the Definitions Worksheet. And here we identify for you the complete numerator and denominator definition for each of the target areas that are included in the PEPPER. So you can see we have 3 target areas here that are focused on live discharges. These 2 are new as of the most recent release of the PEPPER. The original PEPPER only had 2 target areas, live discharges and long length of stay. And so we've added target areas as time has moved on. CMS has asked us to look at additional topics, and so we've added a number of target areas. We have 4 different target areas that are focused on different levels of care provided in either assisted living facility, nursing facility, or a SNF. We've got newly added a single diagnosis coded, and then also episodes with no GIP or CHC. So this worksheet will show you the complete numerator and denominator definition of how we are calculating these statistics. One thing I want to call your attention to is you'll notice that all of these target areas are based on the episodes, the beneficiary episodes of service. And I just want to mention a little bit about the episode and what that means in the PEPPER. When we refer to an episode in the PEPPER, essentially what we are doing is we are stringing together the claim for one beneficiary to basically represent a beneficiary's course of treatment so that we can summarize the hospice claims data in the PEPPER. So we're stringing together the claim, and as long as there's not a gap of more than 60 days between the end of one claim, the through date, through date of one claim and the from date of the next claim, then those claims are going to be strung together to create an episode. If we have a gap of greater than 60 days, or if the beneficiary is discharged, or there's a discharge status code there, then we would consider that the ending of one episode and the beginning of a new episode, and the statistics would be counted within each episode of care there. So do keep that in mind, that we do create these episodes, and so the statistics in the PEPPER are calculated based on episodes. Oh, one other thing. We recently added hyperlinks within the PEPPER. So for example, you can see here that if we hover over the live discharges cell, we have a hand. We click on the live discharges, and it takes us to that particular report within the PEPPER. So it's just a way to navigate within the PEPPER a little bit easier. If you're wanting to get back to the definitions worksheet, we can click on that link here. Takes us right back. All right, the next report that I want to review in the PEPPER is called the Compare Targets Report. And I usually refer to this report as the heart of the PEPPER. It will list for you, and it's the only place where you can see all of the target areas for which you have reportable data or sufficient data to report for the most recent fiscal year. It's also the only place in the PEPPER where you can see your exact percentile for each of these target areas. So let me walk you through this. So for this first target area, live discharges not terminally ill, we have an abbreviated description of the numerator, the denominator here. This is the numerator count, the target count. So this is the number of beneficiary episodes that were discharged alive, no longer terminally ill, in the most recent fiscal year. So when we compare that to all discharges, this provider's target area percent for this target area is 9.3%. So remember, standing alone, we don't really know how our hospice compares. We know that we have 9.3% of live discharges that are no longer terminally ill. So when we compare ourselves to all of the hospices in the nation, our national percentile for this target area is 53.1. So if you think back to that latter example, where the target area percents are sorted from highest to lowest, for this target area, compared to all hospices in the nation, this hospice is right at the middle, where 53.1% of the hospices have a lower target area percent than our hospice does. So the national percentile tells us where within that distribution does our hospice fall as far as this particular target area percent. When we compare ourselves to all of the hospices in the jurisdiction, 49.2% have a lower target area percent than we do. So again, right about in the middle of that distribution, thinking about the latter example. And when we compare ourselves to all of the hospices in the state, 58.3% of them have a lower target area percent. So again, this is a way for you to understand where you fall within those distributions, and it's the first step in thinking about whether there's anything that you might need to be concerned with as far as your statistics go. We also calculate the amount of Medicare reimbursement that the hospice received for these numerator discharges for the most recent fiscal year. So this hospice received about almost $4 million in Medicare reimbursement for these beneficiaries who were discharged no longer terminally ill. So as we look at this hospice's compare report, scroll down a little bit, we can see that for the most part, this hospice doesn't have a whole lot of what we call target areas where they're outliers. They're not at or above the national 80th percentile for very many, just this one. As a matter of fact, when we're looking at live discharges for revocation, this hospice is at the very bottom of that distribution with only 1.6% of the hospices, 1.6% of the hospices in the nation having a lower target area percent. So almost at the very bottom. Now, of course, the higher your national percentile, the higher you are towards the top of that distribution, and that may be an indication that you will ask yourself, do these statistics make sense for me given what I know about my organization? For this routine home care in nursing facility target area, this provider's percent of 51.4 places them at the 88.8 national percentile. So 88.8% of all of the hospices in the nation have a lower target area percent. And so the visual cue here that you're above the national 80th percentile is that the target area percent is color-coded in red bold font. So this is a nice report. I always think this is the first place that providers should go to check out how their statistics look for the most recent fiscal year. What target areas are they an outlier in, if any? And take a look at their percentiles for the target areas that are included in that release of the PEPPER. Again, this is the only place where you can find your exact percentiles. These are the percentiles for your hospice. So let's move on and talk about live discharges. This target area, which has been renamed live discharges no longer terminally ill, this was one of the original target areas that was included in the Hospice PEPPER. Many of us know that live discharges have been the focus of a lot of attention over the past few years in the hospice setting. The hospice benefit is designed to provide care for terminally ill beneficiaries. Although beneficiaries can be discharged appropriately alive from hospice care for several reasons, if they're determined to be no longer terminally ill, if they move out of the service area, they can be discharged for cause, or the beneficiary could themselves decide to revoke the hospice benefit. Now we have 3 target areas that are now focused on live discharges in some form. This particular target area is focused on the percent of beneficiaries that are discharged alive as no longer terminally ill. So what that means is that according to the Medicare claims data, the beneficiary was discharged alive, so the patient discharge status code was not equal to 40, 41, or 42. We do exclude transfers, which is the discharge status code of 50 or 51. We exclude revocation, which is occurrence code 42. We exclude discharge for cause, condition code H2. And we also exclude when the beneficiary moves out of the service area, condition code 52. So really and truly, what's left then are those beneficiaries that according to the claims data, appear to be discharged alive and no longer terminally ill. Now, when you look at each of the target area reports in your PEPPER, they are all formatted in this same general way. So what you will see at the top of your report is a graph that will display your hospice's target area percent, which is this blue bar, over the past 3 fiscal years. So fiscal year 2013, fiscal year 2014, and fiscal year 2015. These 3 red trend lines on the graph represent the point for the 3 comparison groups that is at the 80th percentile. So the red solid line is the 80th percentile for nation. The dashed line is the 80th percentile for the jurisdiction comparison group. And the dotted line is the 80th percentile for the state comparison group. So you can see how your target area percent may be changing over time. In this case, this hospice has seen a steady decrease in the percent of beneficiaries discharged alive as no longer terminally ill. And we can also see that they are below the 80th percentile for nation, which is the largest comparison group, and we use the national comparison group when we're identifying what we call outlier status. Below the graph is a data table that identifies the target area percent for the 3 time periods. We see the numerator count, so these are the live discharges no longer terminally ill. We see the denominator count, which are all of the discharges. We also calculate the average length of stay for the numerator and for the denominator. And again, where available, where we can calculate the Medicare payment amount, we include the average payment and the sum of payments. This is for the numerator. Below that is the comparative data table, which identifies the target area percent that is at the 80th percentile for nation, jurisdiction, and state. And these are the values that are graphed as the 3 red trend lines up here in the graph. Now, if you're thinking that your percentiles from the Compare Targets worksheet should match these, they won't. These are the 80th percentile. That's the 80th percentile for these 3 comparison groups for this time period. When you look on your Compare Targets report, these are your exact percentiles where your hospice stands. So don't get confused about that. Now then at the bottom, at the very bottom of each of our reports, we include what we call suggested interventions. And these are things that you could think about if you have a high target area percent, if you're at or above the national 80th percentile. And so these are generalized suggestions that have been developed in coordination with CMS, just some things that you could think about. So what might it mean? What might you need to do if you are an outlier for this particular target area? Well, you might want to think about whether you have beneficiaries who are appropriate for the Medicare hospice benefit. You would want to review the hospice eligibility criteria for those admissions and make sure that they are met. Review your medical record documentation and determine if that was all appropriate. Another bit of information that I will give you or guidance is sometimes we'll get questions through our help desk from hospices that say, look, there's no way that my live discharge rate is so high, your statistics are wrong in the PEPPER. And Well, we will go back and take a look at the claims data. Again, all of these statistics are calculated based on the claims data that are submitted by the hospice to the MAC. And generally, we will find that the improper discharge status code is assigned. That is, perhaps the beneficiary did die, but the discharge status code did not appropriately identify them as deceased. Or perhaps the revocations occurrence code isn't being used properly, or the transfers, or any of those other codes that we exclude are not being applied on the claim form correctly. And so that's another piece of the puzzle to look into is your billing process, and are those codes being applied correctly on the claim form so that when we process the claims data, these statistics are calculated in accordance with what you would expect. And it is very important for you when you're reviewing your PEPPER, even if you are an outlier for any of these target areas, to think about, does that make sense for you? Do you know that you've had a lot of beneficiaries who have revoked the hospice benefits? Do you know that you have had a lot of beneficiaries with long lengths of stay, those types of things? And is that something that you would expect given what you know about your organization operationally? Because remember, these statistics are identifying the top 20% for each of these target areas as outliers. That doesn't necessarily mean that anything improper is occurring. It just means that your statistics are in the top 20% and asking you to think about whether that's reasonable, what you know about your organization. So I mentioned that we added a new target area for live discharges for revocation, and this was just added to the most recent PEPPER. Here, what we are calculating is the percentage of episodes where the beneficiary revoked the hospice benefit, occurrence code 42. So the beneficiaries can revoke the hospice care at any time, and they can decide to re-elect and receive hospice care again later. The hospice, however, cannot revoke the beneficiary's election or request that the beneficiary do so. Over time, CMS has identified concerns related to patterns of revocations and elections of the Medicare hospice benefit, perhaps for the purpose of avoiding costly hospitalizations or expensive procedures or drugs or other services. And CMS is concerned that patterns of discharge, hospital admission, and then hospice readmission may not provide the beneficiary with the comprehensive and coordinated care experience that they need being a terminally ill patient. So they have asked us to add a target area looking at live discharges for revocations, and that's exactly what we're looking at here. So this particular provider has relatively low target area percent, as you can see for these 3 fiscal years. They are well below the 80th percentile for the 3 comparison groups. If I were looking at this PEPPER, if this is my provider, I would say, okay, well, that doesn't look like it's anything that we need to look into further. Again, below the graph, we have the numerator, well, the target area percent, the numerator count. So this is the number of revocations they had during each of those fiscal years. The denominator, again, we have the average length of stay for the numerator and the denominator, average and sum of Medicare reimbursement. If you do happen to have a high percent of live discharges for revocations, might want to look at, again, your claims submission process. Are those condition codes applied, occurrence codes applied properly? Was that code correctly assigned? If you're aware that you have a lot of beneficiary revocations, it might be a good idea to come together as a team and talk about those instances. Make sure that it is truly the beneficiary's decision and that there isn't any pressure from anywhere within the organization for the beneficiary to do that, to revoke their benefit. The other target area that we've added on live discharges is pertaining to lengths of stay from 61 to 179 days. So here we're looking at the percentage of episodes with live discharges that had a length of stay 61 to 179 days. CMS asked us to add this to monitor the impact of a new payment rate for routine home care starting with day 61. So beginning October the 1st, 2015, which will be for fiscal year 2016, and we'll see that time period added to next year's PEPPER, CMS implemented a higher RHC payment rate for the first 60 days of care, and then after that, the routine home care payment rate goes down. So there is a concern that there may be a financial incentive for hospices to discharge patients after that first 60 days once that lower payment rate takes effect. And so this target area was designed to measure that particular concern. Hospices that have a high proportion of beneficiaries with a long length of stay who are discharged alive, they might be admitting beneficiaries who just don't meet that eligibility criteria. And so that this is sort of tags on with all those other concerns that we've already talked about. Now this particular hospice, although they were very close to the 80th percentile in this oldest time period, we do see a steady decrease here, or a slight decrease, I guess you could say. This hospice probably doesn't have a whole lot to be concerned with, unless when they look at these statistics, they think to themselves, something's not jiving and I don't feel right about this and we need to do some investigation. All right, moving on. The long length of stay target area has been included in the Hospice PEPPER since the initiation, and this was designed to focus again on those longer lengths of stay, which have been a concern that's been highlighted by MedPAC as well as other law enforcement agencies. Of course, some hospices have had beneficiaries who stay in hospice for years, and that really does seem to be a concern, an abuse of the Medicare hospice benefit. So this target area looks at the episodes where the length of stay is greater than 180 days, or roughly 6 months. This particular hospice has a fairly steady percentage of beneficiaries with a long length of stay, right around 15%. They are below the 80th percentile for the 3 comparison groups. So this may be something that this confirms what they've known, that they don't have an unusual amount or unusual number of long lengths of stay. We have all the same statistics down here for this particular target area that can supplement your analysis. Now we have a couple of, actually 4 target areas that look at different levels of care provided in longer-term care facilities. And these target areas were added a couple of years ago as a result of an OIG study that found that there were concerns of hospice care being provided for beneficiaries residing in an assisted living facility, and we also decided to look at nursing facilities and skilled nursing facilities. This target area looks at continuous home care provided in an assisted living facility. So what percentage of episodes that indicate that the beneficiary resided in an assisted living facility and had at least 8 hours of continuous home care provided while they were in the assisted living facility. Since the continuous home care is billed on an hourly basis, we're looking at the threshold of at least 8 hours of CHC. CHC is a costly level of care, but it only represents about 0.4% of all hospice days of service. Now, I want to tell you that if you get your PEPPER and your target area report for this target area looks like this, that would not be unusual. Only about 5% of hospices have reportable data for this target area. And when I say reportable data, there has to be a numerator count of at least 11 for a time period and a target area in order for those statistics to display. And so what that means is that when you see no blue bars on the graph, when the data table is completely empty, as we see here, this hospice did not have at least 11 episodes where the beneficiary resided in the assisted living facility and had at least 8 hours of continuous home care in a year. So don't be surprised if you see this report that has what appears to be missing data. It doesn't mean that there's anything wrong with your PEPPER. It just means that you had very low volume for that particular target area. And sometimes for some of the target areas, you may see 1 or 2 time periods that have blue bars, but none for a third. And that just means, again, that for that particular time period, the numerator count drops below 11 and the statistics are suppressed. We also have a target area that focuses on routine home care that's provided in an assisted living facility. I'm going to scroll through these a little quickly because they're related in a way. Routine home care provided in a nursing facility. And here's an example of when I mentioned there, this provider did not have a numerator count of at least 11 for that oldest time period. And here we have routine home care provided in a skilled nursing facility. Now, it's not unusual for us to get questions from hospices about any of these target areas, asking us how did we determine that their beneficiaries received care in an assisted living facility or in a nursing facility or in a skilled nursing facility. This information comes off of the claim. There's the Q code, the site of service code from the claim, which is completed by the hospice, and that is how we identify where the beneficiary is residing, where those services were provided. And sometimes the hospices will learn that they've been using the incorrect code, Q code, site of service code. Also, on previous trainings, I've had questions such as all of the providers in our state are classified as, let's just say, assisted living facilities. They're not licensed as a nursing facility, or they're not licensed as a SNF. And so we have a high target area percent for this target area. And so my response to that situation is, then it sounds like you would expect to have a high proportion for that target area. And that's okay. As if that's what you expect, simply because of the way that your state licenses those long-term care providers, then you would expect your statistics to look that way, and it probably is not something that you need to spend a lot of time being concerned with. One of the things that popped out to me when I was looking at this particular PEPPER is you can see that there was no routine home care in a nursing facility in the oldest time period. However, we have reportable data in the most recent 2 time periods. The SNF, the routine home care in a SNF graph, looks a little different. So it could be that this hospice realized that they were improperly using that site of service code to indicate skilled nursing facility instead of nursing facility, and that's why the statistics look a little different here. I also want to mention that we've got a couple of resources on the website. There's a job aid that was developed by National Government Services on site of service code, and there's also the CMS MedLearn Matters 8877 that has some really good information on site of service code. Okay, quickly, single diagnosis coded. This is also a new target area that we just added last year for the most recent PEPPER. CMS asked us to identify claims where there's only one diagnosis coded. CMS is really working hard to educate providers to code all of the conditions, all of the comorbid conditions that are under active treatment for the beneficiary. And that's so that, that CMS can have a more complete picture of the beneficiary's condition. And the coding guidelines also specify that all of those coexisting or additional diagnoses related to the terminal illness and related conditions, those should all be reported on the claim form. So CMS has asked us to bring this a little bit more attention by including it in the PEPPER. And so for this particular hospice, you can see that for the very oldest time period, they did have actually 100% of their claims. All of their claims had just one diagnosis coded. And you can see how over time, this hospice has had improvement in coding additional diagnoses when they're available. And you can also see how the 80th percentile has trended downward as well. A couple of comments here that I just want to share with you for your consideration. If you are a high outlier for this particular target area, start with the documentation that you have in your medical record. Does that information include the beneficiary's information about the beneficiary's entire medical condition, their entire picture as they are when you admitted them? If not, perhaps they're not getting all of the information from any referring providers that are referring that beneficiary for the hospice benefit. Another potential missing link is the person who's actually coding those records. Are they aware that they should be coding not just the terminal condition, but all of the other coexisting conditions as well? And then lastly, and this was something that one of the national associations contacted me with, they had been informed that one of their members was anxious to look at their PEPPER because they had been really working hard on improving the coding of additional conditions. And when they got their PEPPER, the statistics did not look as they had expected. And they did some investigation and found out that there was a setting within their billing software that they needed to designate that all of the secondary diagnosis codes should be submitted along with the claim to the MAC and not just the principal diagnosis code. So they made that adjustment, and all of those conditions, all of those coexisting conditions will be submitted moving forward. But there are a lot of little intricacies that you can think about when you're looking at your statistics, and if you know that you've been making some efforts to improve here and the PEPPER data don't show it, then maybe there's something else going on. And the last target area that we added was on no general inpatient care or continuous home care. This target area was added to address the concern that there are a fair number of hospices that don't provide any general inpatient care or continuous home care. And the Medicare conditions of participation do require that hospices can provide all 4 levels of hospice care. When CMS looked at this, they found that 77% of beneficiaries didn't have any GIP, and 57% of hospices did not bill at least 1 day of continuous home care. And so we've added this target area to identify instances where the beneficiary did not receive any GIP or CHC. So the beneficiary did not receive either of these levels of care during their entire episode. So if your PEPPER identifies that you have a high target area percent for this, start asking yourself the questions about whether you're fully staffed and you have the capabilities to offer those levels of care, and if the staff are appropriately identifying instances where the beneficiary may actually need those levels of services and communicating that along so that the beneficiary can receive those services as needed. Okay, I'm running short here, so I'm going to quickly just mention there are a couple of other reports in the PEPPER that don't have any impact on whether you're an outlier or not, but they do identify for you the top terminal conditions for your hospice for the most recent fiscal year. And these are the top terminal conditions that CMS has identified. The report will list for you the terminal condition, the total number of decedents for each of those conditions, the proportion of decedents for that condition to all of the decedents, and then the average length of stay for that condition. And this is really mainly for your own information, and you can compare your statistics with the next report, which is summarized at the jurisdiction level. So you can see the same type of information, but simply at the jurisdiction level, and some of that might be helpful or interesting for you to look at. Okay, so let me go back to my presentation and move things along here. So how do you get your PEPPER? I've mentioned that it's distributed annually in electronic format. It's an Excel workbook. And the way that you would get your PEPPER is through our website, the PEPPER Resources portal. We do have the PEPPERs available there. They are available for 2 years from the original release date. And occasionally we do get requests to email the PEPPER, which we cannot do because CMS considers them to be sensitive data. Now, you will need a couple of pieces of information so that we can validate that you are an authorized person to receive the PEPPER. We need for you to, first of all, have your 6-digit CMS certification number or your PTAN. This is different from your tax ID or your NPI. And then also, we ask that you use a medical record number or a patient control number from a claim that was submitted for a traditional fee-for-service Medicare beneficiary during September of last year. You would find the medical record number or the patient control number on the UB04 claim form at the top. I've circled on the little tiny screenshot of the UB04 where you can find that. Some people also get their medical record numbers or their claim patient control numbers from the remittance advice that is sent back from the MAC. And just a comment that each time we release a new set of PEPPERs, you will need a new validation code. Okay, let me go and walk through the process of obtaining your PEPPER. So this is our website. This is the home page of the pepperresources.org website. You can see that we do generate PEPPERs for a number of different provider types. Here's the section for hospices where you can access the user's guide. You can get to our training and resources page. Here is the PEPPER distribution, get your PEPPER page, and we also have relatively new developed these maps that show PEPPER retrievals by state. But to get your PEPPER, you'll click on the PEPPER distribution, get your PEPPER link, which brings you to this page that describes how the PEPPERs are distributed for your provider type. So here's the row for hospices. The next hospice PEPPER is going to be released around April 17th of next year. There is a link here to the PEPPER Resources portal. Before I click on that, scroll down a little bit and show you that we have some guidance for providers to access their PEPPER through the PEPPER Resources portal. Scroll down further on the page. Once you have your 2 pieces of information, you simply click on the link to the portal, and you will certify that you are one of these individuals with your organization, and you'll fill in the fields here. And then when it comes down to the provider type drop down, you will select hospice. You will enter your 6-digit CMS certification number here. And I have a test account that I'll enter. And then in this field, you will enter your validation code. So this is going to be the patient control number or the medical record number that you were able to obtain from the claim form or from your remittance advice. Once you have those two pieces of information entered, click the Submit button. And if everything matches, the next screen will allow you to download your PEPPER. Actually, you'll see two PEPPERs here. You'll see the new release of the PEPPER, which was going to have Q4FY15 in the file name. And you'll see Q4FY14, which is the PEPPER from last year. So you'll be able to download both of them if you need to. I do encourage folks to always save, click on the link, and save their PEPPER to a location on their computer where they can access it in the future. If you don't do that, then you'll have to go through all of these steps to get to your PEPPER again. And so best to avoid all of that by saving your PEPPER to your computer. At that point, you can print it out, you can email it to somebody else, or share it in another way as you desire. Now, there are some providers who will have to contact us to obtain a special validation code, and you will know that when you enter your provider number and you click on the validation code box, and you have a message pops up that tells you you are required to use your TMF assigned alternate validation code. If you do not have that, please contact the PEPPER team. And this will be a link to our help desk, and we can work with you to get you that code. Then when you would come back to this screen, you would enter all this information, you would type in that alternate validation code, and then you would be able to get your PEPPER. The last thing that we want you to do is struggle with getting your PEPPER. So if you have trouble, if you've tried several validation codes and you're just not having success, please contact us through our help desk on our website, and we will respond promptly to assist you. We want you to get this report, and so we don't want it to be a frustrating struggle for you. Okay. All right, this hospice PEPPER is a lot longer than the home health one. It's taken me a little bit to get through here. Okay, so now that you have your PEPPER and you're looking through it, and let's just say that you see a lot of red and you're concerned. First thing I ask you not to do is don't panic. Remember, these are comparative data reports. We are identifying the top 20% of providers by default, and so outlier status doesn't necessarily mean that you're doing anything wrong or that you're going to be, the subject of a review. But we want you to look at these data and ask yourselves if they make sense, again, given what you know about your organization, your staff capabilities, your community, your referral patterns, referral sources, that type of thing. So just do make sure that you are following the best practices, even if you're not an outlier within the PEPPER. If you do need help, contact us through the help desk, and one of our team members will promptly assist you. This is the screenshot of the website that we were just on. I've circled the section there for hospices. And finally now, Heather, we're ready to move into some questions and answers.
Great, thank you so much. At this time, we'll move into the question and answer session of today's call. If you have a question, please use the chat feature at the bottom right of your screen.
Heather, while we're waiting, let me mention one of the common questions that we get is how many people can access the PEPPER at my organization? There's not a limit. I mean, as many people from an organization can go and access that PEPPER. As long as they have the validation code, PEPPER can be accessed multiple times by an individual. So it's not a problem if 3 or 4 people within a hospice want to get the PEPPER.
Well, it doesn't seem like we have any questions from our attendees as of right now. So I'd like to take this time to thank you all for joining us during today's webinar. I would also like to thank our presenter, Kim, for sharing her expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you have a wonderful afternoon.
Thank you. Have a good day.